Excretion. The topic of today, excretion. Excretion is the process, or some of processes, providing removal of waste, toxins, drug. Excretion. Removal, elimination from the body. Removal. At first, metabolic wastes. For example, urea. Wastes. Not just urea, but waste of protein metabolism. Wasted like urea. Other waste, toxins. Maybe toxins. Exogenous toxins. Endogenous due to activity of microbiota, pathological microbiota, toxins, drugs, or drug metabolites, drugs, and excess of useful substances. It's very important. Excess of useful substances. Useful substances like water, salts, sometimes glucose maybe in diabetic person, salts. So excretion provides two important functions. First, cleaning of the body, cleaning blood, and second function is homeostatic, maintenance of homeostasis, important organ to maintain homeostasis, homeostatic function. Regulation of, at first, volume, blood volume, total blood volume, ionic salts, ionic content, ions, water salts balance. It provides water salt balance. Due to reabsorption or secretion, hydrogen ions and bicarbonates, kidney has participants in pH maintenance, rigid constants and significant constants, pH. Due to removal of water and the synthesis of renin, kidney provides blood pressure regulation, one part of a slow blood pressure regulation. And another important variable, osmotic pressure. Significant water cell balance. Because the osmotic pressure depends on ions and organic substance glucose. The osmotic pressure is created at first by ions.
Salts, proteins.
Yes, salts. So main salt in extracellular fluid is sodium chloride, but not only. Main sodium chlorides and glucose. They are main substances creating osmotic pressure in internal environment, at first blood. Ionic content is a wider range. It includes also sodium chloride, but not only potassium, magnesium, calcium, phosphate, so it's more.
It's anchoric pressure, yeah? Anchoric pressure.
Anchoric pressure is protein. Come in. So, kidney has homeostatic functions. Osmoregulation, osmotic regulation, osmoregulatory, volume regulatory, iron regulatory, pH, and blood pressure. Just remember it, because for each variables, body has receptors. Osmotic pressure is controlled by osmoreceptors. Sodium chloride, sodium receptors, and water, content of water, water and the blood volume receptors, blood pressure, baroreceptors, pH, chemoreceptors. We will study it next class, next week. Body, half the body. Значит, chemoreceptors located in carotid sinus and aortic arch. Значит, aortic arch together, work together, system work together, aortic arch and carotid sinus. Each variable has receptors. Affect receptors tunes off receptors reflex or humoral mechanism, turn off mechanism to recover the main variable with kidney. Not only kidney, of course, but with kidney. So remember it. It exists in my video presentation, but there are another order. Now I explain to combine information step by step. And homeostatic function of kidney is crucial for medical problem. If a person has problem with kidney, usually it destroys disorders, some variables, and a person can have deficiency of sodium or excess of sodium in the blood, shift of balance, osmotic pressure, shift of water-salt balance, hyperkalemia, hypokalemia maybe, deficiency of water or hyperhydration. Everything depends on balance inside kidney, between kidney work and regulatory processes. It work together, so you must understand the physiology part of the pathophysiology of kidney and combination with regulatory process. Homeostatic function, and kidney has some functions more. Metabolic function, I will not write. Metabolic function, because kidney can cleave single amino acid from proteins and fill storage in the blood. If you don't have enough protein with food, kidney may cleave amino acid from proteins and supply blood with amino acid to provide anabolism. Urgent anabolism.
Which function?
Metabolic function. Gluconeogenesis happens here, like liver, and synthesis of new proteins. This is like liver, but not so a lot of function like liver. Metabolic function, homeostatic, metabolic, clinic. Regulation of blood levels. This is excretory function. The rest of function non-excretory, but it's result of one function more, regulatory function. Regulatory function because kidney synthesize some hormones or hormone-like substance. Renin activates renin-angiotensin-aldosterone system. Erythropoietin, you know,
Yes.
And some local hormones like prostaglandins. Four functions. 1, 2, regulatory, metabolic. Then excretory organs. Organs of excretion, main organ of course kidney, but not only kidney, we have other organs helping kidney and providing excretion of excess waste or water. Gland, exocrine gland, salivary gland. Saliva contains urea, you know. Saliva contains urea, waste, okay, contain waste. After drinking, your alcohol metabolizes to acetaldehyde, then acetaldehyde into acid, and acid, acetaldehyde are excreted by kidney with urine and saliva, gastric juice, respiratory airways, and smell after drinking, and respiratory and skin sweat. If a person has problem with kidney, deficiency of kidney function, other organ gets this function more. This person will have bad smell from mouth, from skin, or if this person has more waste like diabetic person. Kidney not enough, function of kidney not enough to clean blood quickly, so this person evaporates more bad waste substances from surface of respiratory airways, skin, from stomach, saliva, and bad smell. Bad smell sometimes is a signal about bad smell from mouth. First signal may be problem with the oral cavity, with teeth, inflammation. If you exclude it, so it may be problem with stomach. And third, maybe problem with kidney, deficiency of excretion. Or fourth, problem with metabolism. Not just oral cavity. It's necessary to investigate. If your patient, for example, complains for bad smell, not just oral cavity. Well, very well. The rest I will discuss just about kidney. Functional unit of kidney is nephron. I'm sure you studied nephron so much in histology. Well, repeat that in mind. Nephron. Nephron consists of three main parts. No, two parts, the big parts. Renal corpuscle. Renal corpuscle compounds of Bowman capsule, renal capsule, and glomerulus. Glomerulus is the capillary bed, special capillary bed inside the capsule.
Sinusoidal.
No, fenestrated, not sinusoidal. Sinusoidal only in the organ producing blood for delicate. Red bone marrow, spleen, and liver. Here fenestrated, not sinusoidal. Fenestrated capillaries. Capillaries are formed by wide arterial. It's called afferent arterial, and then capillaries collect to another arterial, efferent arterial. This is a special case when capillaries don't collect to the veins, collect to arterial again, because these capillaries don't provide substance exchange. They provide another process, filtration, only filtration, without exchange, capillary exchange. Filtration. It provides filtration. The first process of urine formation. Filtration of plasma. Plasma filtration. Next big part of nephron is tubules. Nephron has several tubules. At first, proximal convoluted tubule. Proximal convoluted tubule, PCT. It's abbreviation. Proximal convoluted tubule. Then next one. Henle loop. Henle loop has two functional parts. Ascending down, ascending, thin, ascending, and descending. Zaraz put an abbreviation. Descending part, ascending, thick ascending limb. Descending limb. Ascending limb has two parts, thin and thick. Thick ascending limb. Thick ascending limb. Why it's better to separate functions of thin ascending limb and thick ascending limb? Because they have different mechanisms of transport. If you remember, I asked for the first colloquium, mechanism of reabsorption in the digestive tract. Maybe you will not use in your practice mechanism of reabsorption in digestive tract, but the same mechanism work in the kidney, and you can use this knowledge again. A thick ascending limb has different mechanism compared to thin ascending limb. Henle loop.
Excuse me. Surrounding this tube, it's capillary, yes? Surrounding.
Yes, I will say about it. Then, thick ascending limb then goes to another tubule, distal convoluted tubule. Distal convoluted tubule. I showed here alone in horizontal plane, but actually now shape of nephron is another. So first part, distal convoluted tubule is called macula densa. Macula densa in real nephron. This is skin, we should explain, but in the real nephron, macula densa is located near afferent and efferent arteries. It's very important to provide renin control. Macula densa must be here. Macula densa.
Professor, can I change the place of this because we don't have enough place to sit?
Here a chair. Here a chair. You can sit here. Empty area, empty space. And another chair here. Yeah, sit here. Так, second part, okay, second proximal convoluted tubule. Proximal convoluted tubule, Henle loop, distal convoluted tubule. And the last part of distal convoluted tubule is called connecting tubule. Did you study connecting tubule? Before collecting
Tube for accumulate urine.
do you mean concentration?
Yes.
Concentration next, collecting down. Connecting tubules is a short tubules Connecting means transmission of urine between distal convoluted tubule and collecting duct. Histology doesn't include collecting duct into nephron. Histology. In accordance with histology, because I had no discrepancy between physiology and histology and communication with my student. And now I know that histology doesn't include next part, collecting duct into nephron. Why? collecting duct? Because collecting duct collect urine from several nephrons. There's one collecting duct.
Several nephrons.
Yes, collecting duct. Several nephrons. So histology doesn't include. These nephrons finish here in histology, but physiology includes different approach, but we will include because collecting duct change concentration of urine. Concentration and some composition of urine. So it has function to form final urine, and we will include collecting duct into nephron composition. What is the difference between distal convoluted tubule and connecting tubule? Very important distance in the urine concentration, because distal convoluted tubule impermeable for water. It doesn't have aquaporins. There's no aquaporins here. And first aquaporins appear again in connecting tubules and then in collecting duct. It's very important difference in aquaporin content. Aquaporin is channel for water. Aquaporin here, aquaporin here, but not distal convoluted tubule and absent and ascending hand limb. And here we have aquaporin also. Content of aquaporin. I don't say about number of aquaporin. They are different in proximal part and distal part, but not so important for dental. Conclusion. 5 part of nephron: renal corpuscle, consisting of Bowman capsule and glomerulus, proximal convoluted tubule, Henle lobe, distal convoluted tubule together with connecting tubules, and connecting duct. Then about metabolism. Metabolism in kidney very high because the reabsorption of substance, useful substance back to the body requires a lot of energy because it uses primary and secondary active transport. So it requires a lot of energy. And metabolism in the kidney very high. Oxygen consumption is very high. So it must have capillaries to provide oxygen, gas exchange, nutrients exchange. It's a secondary system of capillaries, secondary capillary bed. It's called peritubular capillaries. They are formed by afferent arterioles, peritubular capillaries, and around tubes, around the tubes, tubules. Peritubular capillaries. Peritubular capillaries. Peritubular capillaries. Peritubular capillaries.
For resorption of the
Reabsorption for two goals: reabsorption of useful substance back into blood, and nutrients gas exchange to supply energy and substances cells of tubules, kidney cells, and interstitial space. Do you know about 2 types of nephron? In kidney, 2 types.
No.
Cortical nephrons.
cortical and medulla.
Juxtamedullary. Juxtamedullary nephrons. Cortical nephrons prevail, about 80% cortical nephrons. Kidney has 2 parts, big part, cortex, and medulla. Cortex and medulla. With different osmolarity. It's very important to provide a fast concentration of urine if it's necessary. Osmolarity of cortex. Osmolarity is content of osmotic active substance like sodium chloride. Osmolarity. Osmolarity is potential force to attract water. Osmolarity. It creates osmotic pressure. Osmolarity of cortex is similar blood. Blood osmolarity, if you remember, about 300 milliosmol per liter. The same in the cortex. 300 milliosmol per liter. It's medical unit. But osmolarity in medulla differs, and it increases from the surface of medulla deeper.
Osmolarity for water is 0, yes?
Yes, of course. There's no salts. Значит, this 300 on the boundary again, 400, 6, 80, 800, 900. It may be about 1,000 or more. It's osmolarity gradient in medulla. The medulla. Cortical nephron. Cortical nephron. Renal corpuscles located in the middle of cortex, middle or superficial or deeper, but inside cortex. Renal corpuscle, proximal convoluted tubule, Henle loop, and distal convoluted tubule collects in down. Cortical nephron. Cortical nephron. 80%. They have difference between afferent and efferent arterioles. Afferent arterioles here always more than efferent arterioles. Diameter more. These nephrons are responsible to clean blood. More responsible to clean blood for the first function of kidney. Significant essential function. Juxtamedullary nephron has a renal corpuscle located near boundary between cortex and medulla. Here. And long Henle loop, deeper in medulla. Collecting that. And the peritubular bed in these nephrons, juxtamedullary nephrons, forms another type of capillaries, like this. Vasa recta. Do you know? Vasa recta. Vasa recta. Vasa recta is not curved capillaries. Vasa recta. But I don't know about a chair. I want one chair here. Vasa recta. Yes, you can. Here. I don't need chair. But after lecture, you can take this. You can take this. I don't need. But after lecture, carry back. Okay. Vasa recta. What is the main function of juxtamedullary nephron? Concentration of urine. Concentration of urine. Remember it. Here cleaning, here concentration of urine. Urine concentration.
It has very smolarity.
Because the counter-current multiplier. Counter-current multiplier. I will explain later how does it work. It's very important to have deepest Henle loop going along gradient, osmolarity gradient. Osmolarity gradient provides a rapid water reabsorption. It's very, very fast. I will explain later how does it happen. So let me show morphology. Now about the process of urine formation. Urine formation includes three processes. Filtration, first process, filtration. Next, reabsorption. Reabsorption occurs in every rest part of nephron. Depends on part, but in every part. And secretion. Write it. I will not write because it doesn't understand. Filtration, reabsorption, and secretion. Three processes. Filtration is passive. Reabsorption may be passive, may be active. And secretion is always active transport. Then details about filtration. Filtration happens in glomerulus. Filtration of plasma. This plasma goes across capillary wall directly. This is skin capillaries. Capillary wall. For example, here blood. Capillary endothelium cell. Endothelial cell. Then what membrane? Next membrane. Basement. Okay. Basement membrane. And then internal visceral layer of capsule, formed by special cells, podocytes. Did you study podocytes?
No.
Why? Histology. Podocytes. Did you study
Next
capsule?
topic will be about
Oh, very good. Now we can be prepared. Next topic. Actually, histology teach a lot about kidney. I was surprised, sometimes more than physiology. So you need it.
Yes.
Значит, visceral layer consists is formed by special cells. The cells are called podocytes. The cell has long feet, pedicels, podocytes, and feet, pedicels, podocytes. Pedicels. Space between two adjacent pedicels are connected by special membrane. It's called slit diaphragm. Slit is site for filtration. Slit diaphragm. This name exists in my presentation. You can write them. Glomerulus, filtered membrane consists three parts. Endothelial cells, fenestrated. Fenestrated means pore here.
Window.
Or window, yeah, like window. Windows, but it's not the fully open window. This window has a polysaccharide molecules. You can see in my presentation later. It limits penetration of big molecules or formed element of blood. So it's not like big hole, no big hole. But big pore facilitate filtration to provide high velocity of filtration. Normal in a healthy person, this filter, space.
Don't filter
Must be
glucose.
a connection. And this pore near fenestra, it consists some proteins, negatively charged proteins. This pore has negative charge. Negatively charged due to some proteins. And the filtration barrier, filtration membrane consists of endothelial cell mechanical barrier, fenestra, size of fenestra. Those big proteins cannot go across small fenestra. What proteins are bigger in the blood? Albumin or globulin? Globulin. Because globulins and the person can't go across this fenestra. Globulins has a positive charge, and globulins molecule is attracted to fenestra and form another mesh. Another mechanism limited loss of proteins or formed element. Albumins smaller and can go across the spore, but albumins has negative charge, and negative charge of endothelium they reject, provide going out because negative.
What about keratin?
Proteins, albumins potentially can go across fenestra, but a negative charge pulls out because negative charge. Globulins are attracted, but they are big. If person has inflammation in glomerulus, glomerulonephritis, for example, nephritis, then pore becomes more, and then globulin can go across. This person has a protein in the urine. Analysis.
Proteinuria.
Proteinuria, yes, proteinuria losing of proteins. The next filter, basement membrane. Next filter, podocyte fits and slit diaphragm between them. What problem can decrease filterability? Increase filterability, decrease limitation. Inflammation, histamine increases permeability of capillaries and fenestra size. Losing of negative charge due to mutations, some problem with autoimmune, for example, disease. Destruction of negative charge. Then the situation of a patient can have a losing of proteinuria. A rate of filtration is called glomerular filtration rate. Glomerular filtration rate. How many milliliter goes across into one capsule per 1 minute or per 1 hour. What is the rate? It's about middle average, 125 mils per minute. It's equal 180 liter per day. A lot, but final urine that you extracted, remove, just 1.5 or 2 liters. Just 2 liters. The rest is reabsorbed. It requires a lot of energy. So kidney require a lot of energy. Glomerular filtration rate. How to measure glomerular filtration rate? The medical examination. It's called clearance test. You can inject in body special substance, only filtered in kidney, and compare how much concentration of this substance in the blood before test and after test. For example, after 20 minutes. Then calculate what substance used in medicine to examine glomerular filtration rate. Inulin, not confused with insulin, another. Inulin is polysaccharide. It's not digested, and with insertion into blood, inulin is filtered. It's filtered, and you can measure concentration of inulin in urine. Inulin or creatine. creatine. They used to measure glomerular filtration rate with the examination clearance. Clearance is a coefficient of clearance, blood clearance from inulin or creatinine. Clearance is calculated by equation concentration of inulin in urine inulin concentration, how much inulin in urine after that 20 minutes, volume of urine divided to concentration inulin in plasma before test. That's how much inulin was filtered. You can see it presentation. Glomerular filtration rate, very important medical test in person with problem with kidney or blood pressure.
PIN for means? PIN?
Plasma inulin. P
Oh, plasma
plasma.
inulin.
Plasma.
Plasma.
Concentration plasma, concentration in urine. You will have this formula equation in my presentation. Filtration. So filtration provides a good rate for cleaning. Then body, kidney extract, reabsorb useful substances back. Depending on, in this process is regulated by hormones or neural system to provide homeostatic function of kidney. Reabsorption. There are two kinds of reabsorption, obligatory and facultative. What is the difference? Obligatory reabsorption provides reabsorption of more substances, more amount of substances, more percent, and is not regulated or regulated a little. Obligatory, always. It must be always. It happens in proximal part. Facultative reabsorption provides a little reabsorption, the rest of substances, and is well regulated. It happens in distal part. Because we have reabsorption gradient from more to less volume of reabsorption, and from little regulated to well regulated. In proximal convoluted tubule reabsorbed a lot of useful substances, almost all substances, all organic substances, useful substances, glucose, I will draw everything, glucose, it must be reabsorbed 100%, all glucose in healthy person must be reabsorbed here.
And sodium?
Glucose, glucose 100%. Sodium chloride, sodium chloride. Here the rule of 2/3 works. Special rule, actually proximal convoluted tubule usually reabsorb about 70% of substance, but sometimes more or less, depends on substance. Which is sodium chloride, 65-70% of filtered. This wall is permeable for water. Water allows sodium chloride due to osmotic gradient. The same water. Potassium. Potassium reabsorbed also. Potassium about 80%. Bicarbonates. I will clean. Bicarbonates. Again, a lot, 80, sometimes 90%. Phosphates.
Very amount of mineral is reabsorbed in the proximal part of the.
Proximal convoluted tubule. Until Henry Look. Phosphates, calcium. Look, it's enough for you. Значит, you must know sodium chloride, water, potassium, bicarbonates, phosphate, and calcium. And the total rule, sodium, at least for sodium chloride, about 70%, and water the same 70% because water allows sodium chloride only. Water doesn't have active transport. Glucose, proteins, amino acid must be reabsorbed fully, 100%. Glucose, proteins, a little proteins can be filtered, albumins, a little. It helps the person, then reabsorbed in proximal convoluted tubes. Proteins, amino acid. Oh, now okay. Of course, more substances are absorbed here, but for us, for variables, it's enough to understand this. Then, Hendel's loop has a different reabsorption in descending limb and ascending limb. Descending limb is permeable for water, is not permeable for sodium chloride, just for water. But what is the mechanism reabsorbing water here? This mechanism is osmotic pressure created in another part, ascending limb, because it reabsorbed with active transport sodium chloride. Active, very important.
Excuse me.
Active secondary chloride.
Because medulla part of the kidney
Yes.
is hemostase variable.
Osmotic pressure.
Osmotic pressure.
Yes. Why? It has more osmotic pressure in interstitial of this part due to this transport. There is a Henle loop. Don't forget that juxtamedullary nephron. Especially juxtamedullary nephron reabsorbs always sodium chloride against concentration gradient, because here concentration gradient, a lot of sodium chloride in interstitial. It must work against concentration gradient, so it uses active transport and reabsorbs sodium. It increases osmolarity, osmotic pressure. It increases osmotic pressure, and this osmotic pressure provides gradient to reabsorb water. That's what here mentioned in capsule. In capsule, osmotic pressure of urine is equal osmotic pressure of blood and cortex. 300 milliosmol. In proximal convoluted tubule, when urine is passed across proximal convoluted tubule, wall reabsorbs sodium chloride together with water equally. It doesn't change osmotic pressure, and urine again has osmotic pressure 300. But then, when urine is passing across the descending limb, it reabsorbs water due to high osmotic pressure around, and osmotic pressure of urine increased until equal this part, end of Henle loop. No, maximum 100, 1,000, 1,200 milliosmol.
Apex of Henle.
Yes. So urine becomes concentrated. Has a higher osmolarity concentration, salt concentration. Then urine goes up and removes sodium chloride, and osmolarity urine decreases. It becomes, for example, 90, 60, 40, 30 again, until distal convoluted tubule, and sometimes it becomes less than in distal convoluted tubule. Cortex. Urine becomes dissolved, diluted with lower concentration of salts. Then, in distal convoluted tubule is not like acidic part of Henle loop, impermeable for water, but it reabsorbs sodium chloride reabsorption. It decreases more osmotic pressure of urine. It may be 100 100. And finally, collecting duct may reabsorb more water or it doesn't reabsorb water. It depends on presence of hormone, ADH hormone. If ADH hormone present in the blood, no, usually some concentration ADH hormone is present in the blood always. It may be low or high. ADH high concentration, it opens aquaporin. But here aquaporins is controlled by ADH. ADH doesn't influence obligatory reabsorption because there are another aquaporin, another type. Aquaporin are one type. Here aquaporin 2 channel. This channel is controlled by ADH. Very interesting, да? Obligatory absorption has another type of channel, is not controlled. This type of aquaporin is controlled, facultative reabsorption. And ADH open aquaporins for water. Water may be reabsorbed, and urine becomes concentrated. Maybe finally again
Vasopressin,
vasopressin the same.
yes, it is effect under pressure, yes, increase the
Of
pressure.
course, because
Reabsorb
it's
the
water
water.
retention. Water retention increases total blood volume. One of mechanisms. Yes. If ADH low, another case, ADH low, this channel doesn't work.
Dehydration of the patient.
Doesn't work, and the urine volume increases, and urine becomes diluted. 150,
Пашка, что
100
фильтр сам?
milliosmoles.
So,
So, in presence of high concentration ADH, urine is concentrated, and water we have water retention. In absence or low concentration ADH, diuresis is high, and the urine is diluted. It has low osmotic pressure, different cases. Reabsorption of water has two parts. Obligatory reabsorption happens in proximal convoluted tubule together with sodium chloride. More part of water reabsorbed here, independently of nephron. 70%. The rest part is reabsorbed in a Henle loop and collecting duct. Henle loop is countercurrent multiplier. I will ask everybody during colloquium countercurrent multiplier.
What?
we know which one.
Counter one current against another, different opposite direction. Counter current multiplier. Counter current multiplier. Not from word play, multiplier. From word multiply, increase. Multiplier, increase. Counter current multiply. From word multiply, increase. Again, how does it work? Counter current multiplier. At first, there is a osmolarity gradient between cortex and medulla. This gradient is created by active reabsorption of sodium chloride in the thick part of ascending limb. Next point, there is movement of urine in opposite direction in descending limb and ascending limb, Henle loop. The descending loop is permeable just for water and impermeable for salts. And opposite, ascending limb is permeable for sodium chloride but impermeable for water. What is different from proximal convoluted tubule? Proximal convoluted tubule permeable for everything, and water and sodium chloride go together. Here opposite, down just water, up just sodium chloride, and both processes helps each other. More water reabsorbed, more concentration salt inside urine, and it helps reabsorb sodium chloride. Reabsorption of sodium chloride helps reabsorption of water. Collecting duct is another part of countercurrent multiplier, but it's facultative. It works just in presence of ADH. But again, countercurrent multiplier, so ADH effect is fast. ADH effect is fast compared with aldosterone. But we will have a virtual experiment and compare effect of. Why are you late? I will late. I don't know if you find. You will like it. Chair. Chair here. John, or here. About sodium chloride, absorption sodium chloride, most part proximal convoluted tubule, 25% in thick ascending limb, about 5% in distal convoluted tubule, and distal convoluted tubule sodium reabsorption is controlled by another hormone, aldosterone. We studied previous colloquium aldosterone.
Yes.
Here we study effect, more effect. How does it work? Aldosterone affects sodium reabsorption and potassium secretion. Because here potassium reabsorbed in proximal convoluted tubule. But in distal convoluted tubule, potassium is secreted. Because excess of potassium, excess of potassium, hyperkalemia, change membrane potential, resting membrane potential, and can stop heart. We studied previous colloquium. It's very dangerous. So we have additional mechanism, facultative reabsorption, to control potassium concentration. Aldosterone affects sodium and water, but aldosterone, you see, doesn't have direct effect to water absorption. But previous colloquium we discussed about effect of aldosterone, renin-angiotensin aldosterone system, and we said that aldosterone increased total blood volume. Why? Its effect lower compared with ADH, but it exists. Why? Because sodium chloride reabsorption increases osmolarity of interstitial space around distal convoluted tubule, collecting duct, and the high part of a collecting duct. And if ADH enough, then water can goes across aquaporin. But aquaporin here, aldosterone affect here. Different sites. So effect of aldosterone is much lower compared with ADH effect to total blood volume. It exists but lower. Main function of aldosterone is to control sodium, potassium content. But sodium content influence on water. How? It's very important to understand the idea. It's connected with this topic. A scheme of our body. Cells body cells, tissue, capillary, blood, capillary, and interstitial fluid. Interstitial fluid. We have two boxes of fluids. Intercellular fluid. More potassium, yes. And extracellular.
Sodium.
More sodium, yes. Extracellular fluid. More sodium here and here. But extracellular fluid consists of circulating fluid into blood, with blood, and interstitial fluid. Exchange of water and salt between capillaries and interstitial fluid happens due to filtration absorption. Capillary exchange, previous colloquium. Capillary exchange, filtration absorption, main force, hydrostatic force, and colloid pressure. Hydrostatic pressure and colloid pressure. Very important. Hydrostatic pressure and colloid pressure. What about exchange of water between cells and interstitial fluid? Cells takes salts, for example, with secondary primary active transporters. But water can go passively across aquaporins due to osmosis. Water can go inside and outside due to osmotic gradient. For example, hemolysis. Do you remember? Erythrocytes and hypertonic solution. Water can go into cells or out cells in accordance with osmotic pressure. And arrangement of water between extracellular fluid and intracellular fluid happens in accordance with salt content, and blood pressure, hydrostatic pressure. So you must remember this with three parts. Cells with interstitial fluids exchange with water, exchange by water with extracellular fluid, interstitial fluid. And interstitial fluid exchange by water and salts with capillaries due to hydrostatic pressure. I forgot to say about force of filtration. It's very important. Force of filtration. Glomerular filtration rate depends on functioning nephron. Not every nephron works in your kidney in healthy person. Only maybe 40% works every time. Why? Because it's reserve. How to exclude nephron from work? You must affect net filtration pressure. Glomerular filtration rate depends on a number of working functioning nephrons at any given moment. Functions of nephron depends on supply of blood supplement, capillary circulation, and net filtration pressure. Glomerular filtration rate depends on net filtration pressure. Equation, net filtration pressure. I'm sure you can remind it from previous colloquium. Net filtration pressure. Net filtration pressure is the force combined from hydrostatic pressure, capillaries. It pushes plasma into capsule, and opposite forces. Minus oncotic pressure, capillaries. Oncotic pressure, colloid pressure, proteins retard water in the blood, and another opposite factor, hydrostatic pressure, capsule. the same equation from capillary water exchange. Difference just it doesn't have oncotic pressure of urine. Why? Because urine doesn't contain proteins or a little in healthy person. Doesn't contain proteins, impossible, or a little. So, we can say that oncotic pressure of urine about 0. So exclude from this equation. Equation actually the same, usual capillary. And hydrostatic pressure in capillaries here is higher than our usual capillaries. To provide usual capillaries hydrostatic pressure was 33. Here about 55 millimeter Hg. High hydrostatic pressure in capillaries is created by difference in diameter, afferent and afferent arterioles, very important. Diameter, afferent arteriole, afferent arteriole, and systemic blood pressure. Systemic blood pressure.
It changes by diameter.
Yes. Remember it, take photo, I don't know if you do everything, remember this fact, very important fact. Hydrostatic pressure in capillaries, main factor provides the glomerular filtration rate. Hydrostatic pressure in capillaries depends on a difference between afferent and afferent arterioles. If afferent arterioles constricts, hydrostatic pressure falls. If afferent arterioles constrict, hydrostatic pressure rises. It's called a ratio between them.
With norepinephrine,
Yes. Norepinephrine, actually some hormones affect differently, have different effect to afferent and efferent arterioles, and I will explain about renin. Glomerulus, tubular glomerular feedback. Tubular glomerular feedback. How does it work? Tubular glomerular feedback. Kidney has local autoregulation. Glomerular filtration rate, because it's a crucial vital process. For example, if glomerular filtration rate decreases, and what happens? Glomerular filtration rate decreases. Juxtaglomerular apparatus responds to it. What is a juxtaglomerular apparatus? We studied before renin. Renin is secreted by cells, juxtaglomerular cells, located on the wall, afferent and afferent arterioles. Did you study in histology? No, you will study. Juxtaglomerular cells. Juxtaglomerular cells. Here. Juxtaglomerular cells. These cells directly release renin. But what factor provides renin release? What factor did you study?
high pressure,
Low blood pressure. Low blood pressure or low blood volume. One factor. No? Another factor, signal from macula densa. Macula densa can stimulate renin release when urine has a low concentration of sodium chloride. Not low concentration, low rate of sodium chloride, low delivery. Because when rate, velocity, it's not correct term, not you understand. Velocity of contact between sodium chloride and macula densa becomes lower, it stimulates renin release.
and reabsorb sodium.
Stop. Don't distract me. Потому что everybody will, you understand, but the rest. It's difficult to follow new topic. Значит, decrease glomerular filtration rate. It decreases rate of sodium chloride delivery at contact with macula densa. Macula densa stimulate juxtaglomerular cells. They release renin. Renin activate, converts angiotensinogen to angiotensin 1, then it forms angiotensin 2. I will pass it. Finally, we have angiotensin 2, and angiotensin 2 constricts efferent arterioles. It has prevalent effect to efferent arterioles. Constrict efferent arterioles. Efferent arterioles constricts. It increases this. And another effect, decrease release of adenosine cells from macula densa. Another hormone, adenosine, decrease adenosine ATP release from walls and the macula densa. Adenosine constricts efferent arterioles. Less adenosine, so dilation afferent arterioles. Here constriction. Here dilation afferent arterioles. This diameter afferent more, efferent less, hydrostatic pressure rises, glomerular filtration rate rises. And another effect, renin increase blood pressure. Blood pressure is because free factors will be changed. It works locally, local mechanism, self-regulation. Так, well, I will check her presence and then regulation of variables. Так, Feigech. Again. Так, Ханьех.
Yes.
Okay. Так, well, okay. I will clean.
Professor, for this scheme here, about nephron.
This is nephron.
Okay.
This is filtration
No,
basin.
only about nephron. What should we study? You explain about it 50 minutes.
No. Only 50.
What should we
I
study?
will talk for hours. Picture, names,
Okay.
substance, reabsorbed, how many percent sodium chloride, counter current multiplier, and effect aldosterone ADH.
Okay.
Here just name, not picture.
Okay.
Name, equation. This equation is must have it.
Yes.
This equation.
Okay, thank you, Professor.
Actually, it's really very complicated. But I explained just simply.
Yes.
It's simple.
No, primary. Actually, primary. Without many details, more details.
Yes.
What about the reabsorption mechanism? I will draw scheme of reabsorption. Just proximal convoluted tube, because mechanism are different and proximal and distal important study everything, but proximal must it's easy. If you remember digestion, it's easy.
Digestion.
Apical membrane, lumen, and basal membrane to reabsorb into blood. Reabsorption of water. Reabsorption of water happens passively. Water across aquaporin. Aquaporin here, aquaporin here. Water reabsorption. Scheme of reabsorption. Mechanism. Transport mechanism. It's a proximal convoluted tubule. Proximal convoluted tubule cell. Reabsorption of sodium. Sodium from urine in again into body. Sodium potassium pump. Sodium potassium pump here. Primary active transport and secondary active transport pulse with sodium, for example, glucose. Glucose or amino acids, the same digestive, the same reabsorption, same mechanism.
It's cell of the nephron.
Nephron.
And
Then, what about potassium? Main potassium reabsorption passively across paracellular space due to electrical gradient. Electrical gradient. The same potassium, calcium, and chloride.
we don't have a tight function for
No.
between
No.
the
No, maybe там a little, да? Paracellular space. Так, значит, sodium, glucose or amino acid, protein, reabsorption of protein by endocytosis. Protein, albumin by endocytosis. Active mechanism. I think that's enough. Actually, you will study then maybe pharmacology, special antidiuretic, the effect here or effect here, but now we don't have a lot of time. I will talk about it. But it's enough for dental student if you know it. We will study acid-base balance. I will add here reabsorption of bicarbonate, secretion hydrogen, but now I don't want to read. Well, we take water and I will write another script. The rest about control variables with skin. How it works. The more an essential variable osmotic pressure, blood osmotic pressure. Increase osmotic pressure in the blood, for example, due to a lot of salt food, increase or loss of water, increase osmotic pressure, affect osmoreceptor. Osmoreceptors located in hypothalamus. Now, hypothalamus is the main nerve center controlling most variables. Hypothalamus. It has osmoregulatory center. Center osmoreceptor located in hypothalamus. Hypothalamus, it works so. Hypothalamic neuron increase osmotic pressure around, osmotic pressure. Water goes outside due to osmotic gradient. It excites neuron. Neuron transmit information to supraoptic nucleus. Do you remember it? Parvocellular nucleus, hypothalamus. Hypothalamus, okay. Supraoptic or paraventricular nucleus, or supraoptic nucleus. I don't require for dental student names to name, but you must know that it's inside hypothalamus. And this nucleus, neuron, has axon, going to hypophysis, posterior hypophysis, and it release hormone. What hormones?
ADH.
ADH. Hypophysis. ADH. ADH hormone. ADH retent water, reabsorbs water. ADH. More water retention. Water retention, increase blood volume, and dilute sodium retention. It decreases osmotic pressure. It's osmoregulatory reflex, central receptor, but it has our body has peripheral receptors. Peripheral osmoreceptor, for example, liver. And before a class about kidney regulation, I will give homework to draw reflex from peripheral receptors. Your fantasy. Then, it's one mechanism, a primary mechanism. Another mechanism. Next, about sodium receptors, it's a little complicated, I will not explain it. Next mechanism, volume control. This control of osmotic pressure. Another control, very important control of blood volume. Volume regulating mechanism. There are 3 volume regulating mechanisms. Here, osmoregulation. Next, volume regulation. Volume regulation, okay. Blood volume. When blood volume increases, it increases also blood pressure. And 2 receptors work. First, volume receptors and baroreceptors. Volume receptors and baroreceptors. Baroreceptors respond to high blood pressure in large arteries. Systolic blood pressure, aortic arch, high blood pressure. Here, volume receptors are called low pressure receptors because they are located in atria. Blood pressure in atria is low. But effect is similar. Effect of reflexes is similar. It inhibits ADH release. ADH low, water removal, blood volume pulse. Water removal from the body, diuresis increases. Understand? Idea. Next mechanism, renin-angiotensin-aldosterone system. Decrease renin production. Inhibition. Less renin, renin-angiotensin-aldosterone system. And another mechanism, atrial natriuretic peptide. Atrial natriuretic peptide. Removal sodium and together with sodium, water. Water removal. It's enough because you are tired and your brain can't digest the information. But it's main, you must listen. We will play with this mechanism, explain some situation, cases during class. But before you must digest. No.
Thank you, Professor.
We have a conference from the previous session below.
Yes, but I didn't.